reliability and the role of each of these tools in reaching a diagnosis. So the first lecture is on MRI and MRCP is Dr. Vineet Mishra, who is assistant professor at Department of Radio Diagnosis at the Mahatma Gandhi University.
Good afternoon, everyone. First of all, I would like to thank Dr. B.S. Kapoor for giving me this opportunity to speak on MRCP. So MRI consists of basically two basic sequences, T1 and T2. And as all of us know that fluid is dark on T1 and bright on T2 weighted images. So this is T1 weighted images. We can see the CSF around the cord is black on T1 and it is bright on T2 weighted images. And if we increase the T2 weighted factor, then we get heavily T2 weighted images. And in other words, it is MRCP. So on an MRCP, basically any slow moving fluid or static fluid will appear bright, and any other thing in the upper abdomen like liver, spleen, any other organ or fast moving fluid like blood in the vessels will appear dark. So this is how T2 weighted images appear, and this is the MRCP images. We can see the biliary tree here, horizontally oriented right posterior sectoral duct, right anterior sectoral duct forming the right hepatic duct. This is segment 4 duct, and these are the lateral segment bile ducts forming the left hepatic duct. This is primary biliary confluence. This is hepatic duct, common hepatic duct. This is cystic duct opening to hepatic duct, and this is down CBD here. And this is obviously the gallbladder. Now, MRCP can be done through two different techniques. One is the 3D technique, and another is the thick slab technique. 3D techniques required a lot of time, but it is pretty sensitive for small lesions, small strictures, and it is quite helpful in when we are looking for the anatomical variants. Whereas thick slab, it's a 2D image, and it takes only 1 or 2 seconds for image to be taken, and but the resolution is not that great. With 3D image, we get a volume and we can post-process it, and it is quite helpful in diagnosis of like small CBD calculus. This is a thick slab on here, but the region of interest is obscured by the fluid in the duodenum. But when we get a 3D image, we can post-process it and we can remove this fluid, and then this picture is clear. The right hepatic duct is coming down and is opening into CSD along with this into the CSD along with the cystic duct. And now we need to report these cases, and we need to see this anatomical variants, as if this patient is if this patient undergo cholecystectomy, we might end up ligating this duct, or it may be injured and can result in the biliary leak. Another anatomic variant that we usually come across is the right posterior sectoral duct opening to the left hepatic duct. This is how a normal MPD looks like. This is another variant in which the cystic duct is coming medially and opening along with the CBD at the major papilla. We can also see that there is dilation of the main pancreatic duct with few calculi within it. Another anatomic variation that we frequently come across is pancreatic divisum. In this, we can see the main pancreatic duct opening at the minor papilla, and ventral duct is opening at the major papilla along with the CBD. Another variant, the trifurcation pattern, in which there is right anterior sectoral duct, posterior sectoral duct, and left hepatic duct are forming the common confluence, and there is associated pancreatic duct which is communicating with the MPD. MRCP is a non-invasive, less costly, and quite sensitive alternative to the diagnostic ERCP, and its diagnostic accuracy are nearly equivalent to that of the ERCP. We need a patient to be fasting for 4 hours so that we can get adequate distension of the gallbladder and the biliary tree, and this can also lead to reduction in the fluid in the stomach and gastroduodenal secretion, and hence the motion artifact because of the bowel peristalsis. We always take additional sequences with MRCP like T1 and T2 weighted images, and nowadays we are also taking diffusion weighted images. At times when we are suspecting small calculus of the distal CBD, continuous T2 weighted Excel cuts are of great help. And in some cases, we also go ahead with the contrast study. There are a few modifications available nowadays for the MRCP. One is secreting enhanced MRCP, which is done for evaluating pancreatic duct anomalies like small strictures, and to confirm whether there is any communication between the pancreatic duct and any cystic lesion lying in the pancreatic parenchyma or in the nearby peripancreatic areas. Functional MRCP is done after injecting hepatobiliary specific contrast agent. It has got better signal noise ratio as compared to the normal MRCP. Advantages of MRCP are that it doesn't require any intravenous or oral contrast on a routine basis. It avoids complications of ARCP and can be performed on an OPD basis. It's a passive procedure, so it displays the duct in their resting state. There are a few limitations, like first is it is purely diagnostic examination, and there can be a lot of artifacts because of the high amount of fluid in the abdomen in the form of ascites or increased amount of fluid in the bowel loops, which can make the images suboptimal. And MRCP depends a lot on the patient cooperation. A few limitations are like other limitations like dropout of signal, which can be caused by metallic clips, or there can be pseudo obstruction because of crossing defects induced by the right hepatic artery on the CSD. It has got lower resolution than the direct cholangiography. These are the few major indications of MRCP in the cases of bile duct obstruction, choroidal Mirizi syndrome, ampullary stenosis, tumor, cholangiocarcinoma, and sclerosing cholangitis. These are the few pancreatic applications of the MRCP. So the most common indication is obviously the gallstone. In this, we can see that gallstones are usually seen as round or oval filling defects within the common duct. This is a filling defect here. Another case with two calculi there in the CBD. We can also see there are multiple filling defects within the gallbladder, such as cholelithiasis and choroidocholithiasis. This is a case in which the calculus is impacted at the distal end of the CBD with meniscus sign and dilation of the biliary tracts, and there is a stone there in the gallbladder as well. Multiple calculi in the CBD. For gallbladder calculi, I usually prefer USG over MRCP because few small stones can be missed on MRCP. But in one scenario, it is quite helpful in an obese patient or a patient with high amount of gases in his abdomen. The neck might be obscured. So GB neck calculus is another one of the most important indications for MRCP. You can see the stone here impacted at the neck. You can see on the T2-weighted images that there is associated cholecystitis, overdistance of the gallbladder, and biliary sludge. Again, for polyps, I would prefer USG over MRCP. Polyps are visualized as filling defect in a non-dependent position in the gallbladder. Another important indication for MRCP is Mirizi syndrome. Here in this case, we can see a large filling defect here, which is effacing the CSD and resulting in the biliary dilatations proximally. These findings are better displayed on T2-weighted images with the large calculus here, and it is effacing the CSD, and here we can see the calculus there. CSD is not visualized. Another case of Mirizi syndrome where we can see the narrowing of the CSD, dilated cystic duct, wide communication between the CBD and CSD, suggestive of polycystic biliary fistula, and the stone has come down from the cystic duct into the distal part of the CBD. Another indication or the differential diagnosis of filling defect in the CBD is biliary ascariasis, which presents with 3-line sign. This is the case, dilated CBD with tubular filling defect within it. On axial image, we can see the ring-shaped lesion with central hyperintensity, which is fluid within the gut of the worm. This is 3-line sign, one black line followed by a white line, and again a black line. Another same patient, we can see the similar finding in the dilated IHB in the segment 6, suggestive of ascariasis. This patient also had an anatomical variant, trifurcation pattern, horizontally oriented right posterior sectoral duct, vertically oriented right intersectoral duct, and left hepatic duct. Another case with CBD ascariasis, curvilinear filling defect. Patient also had GB stone. This is a case of headed cyst which has ruptured into the biliary tree. We can see a cystic lesion in the right lobe with thin inner internal membranes which are herniating into the CBD and coming down till the major papilla. There is associated biliary obstruction and overdistance of the gallbladder. Now, benign structure of the CBD usually appear as smooth tapering, whereas malignant strictures or malignant masses cause abrupt narrowing and irregularity of the walls of the CBD. In this case, we can also see the dilated MPD, cerebral double duct sign, which is quite characteristic of the carcinoma head of the pancreas. There is another sign, duct penetrating sign, which helps us to differentiate between the pancreatic carcinoma from the mass forming chronic pancreatitis. In chronic pancreatitis, there will be irregularity of the pancreatic duct, and if we can see that pancreatic duct is crossing through the mass, it is unlikely to be carcinoma. Other investigations are like choroidal cyst. In this, we can see that there is fusiform dilation of CSD and CBD. There is trifurcation pattern with dilation of the right posterior sectoral duct. Also, we can see that there is a long common channel suggestive of anomalous pancreatibiliary anastomosis, which is the cause of the choroidal cyst. Another case of the cortical cyst with dilation both intra and extrahepatic biliary tracts, dilation of CSD, cystic duct, and we can also see there is a pancreatic divisum here. Another very similar case. Now, I would like to discuss the importance of the routine MRI images in patients with surgical with jaundice. This is three cases with hilar block, one with the stricture at the anastomotic site post-operatively. This is a Klaskin tumor, and this is a carcinoma gallbladder which has infiltrated into the hilum. We cannot differentiate between these three etiologies just on the basis of MRCP images. We need other images like T2-weighted and diffusion and contrast images to differentiate between these etiologies. This is a case in which there is a obstruction in the hilum with separation of the right and left hepatic ducts. There is also separation at the right secondary biliary confluence. And on T2-weighted images, you can see the mass sitting there. There is also this is second case in which you can see that there's abrupt narrowing of the distal part of the CBD. We are not very sure what is the cause. Either it is a calculus or a mass lesion. If we look at the T2-weighted images, the intensity is that of a soft tissue mass. Here it is a mass, and this is the MPD, and this is a overdistributed gallbladder. So probably we are dealing with the malignancy, distal cholangiocarcinoma. This lesion is showing mild restricted diffusion here. This is appearing white on the diffusion-weighted images. Another case, post-op stricture with a stricture here in the CSD in the primary biliary confluence with a few calculi in the right and left hepatic duct. This is a very smooth thickening, and the lesion was not showing any restricted diffusion. So probably we are dealing with post-op stricture. This is a hilar block due to the carcinoma gallbladder. The answer lies in the T2-weighted images, which shows that there is a mass lesion here arising from the gallbladder and infiltrating the CSD and the primary biliary confluence, causing separation of the right and left hepatic duct. Pancreatic pathologies can also be very well evaluated with the MRCP. Pancreatic divisum we have already seen, and other are the abnormal pancreatic biliary junctions and annular pancreas. This is a case in which there was a long common channel suggestive of the anomalous pancreatic biliary junction. In the same case, we can see that the duodenum is completely encased by the hypointense pancreatic parenchyma, causing the luminal narrowing. Proximal to the pancreas and distal to the pancreas duodenum is normal, so it is a complete annular pancreas. MRCP is obviously very useful for the diagnosis of the cause of the acute pancreatitis. Well, it is quite helpful in the chronic pancreatitis as well. It can shows the complications like pseudocyst formation, strictures, and intraductal calculi, and often the fistula. This is a case of the chronic pancreatitis showing dilated MPD with multiple filling defects within it, suggestive of calculi. Another case with dilated MPD and filling defect in the head. But if we see at the T2-weighted images, we can see that there is hardly any parenchyma left. There is dilation of the side duct as well, and there is a calculus sitting in the proximal pancreatic duct. This is MRCP is also useful to differentiate confirm whether there is communication between the MPD and the pseudocyst, or if the lesion in the pancreatic parenchyma, whether it is communicating with the MPD or not. In that case, it could be intraductal papillary mucinous neoplasm. So this is a T-tube which is placed outside the common duct. These are the few take-home messages from my side. MRCP is a non-invasive method for evaluation of pancreatic biliary disorders, allowing assessment biliary duct upstream as well as downstream from the pathology, as well as extraductal lesions. Patient preparation and cooperation are very important, and we need to perform additional MR sequences, T1, T2, diffusion-weighted, and at times contrast study. And knowing the possible anatomic variants, artifacts, and patient's clinical surgical background will help us to avoid pitfalls. Reviewing the original thin section data, analyzing MRCP images in multiple planes will help us avoid pitfalls. Thank you.
The next speaker, Dr. Mukesh Kalla, Senior Consultant, Gastroenterology, Kalla Hospital, Jaundice. We will be talking about
Thank you, Dr. Kapoor, sir. And Mahatma Gandhi Hospital, I've been associated with the family for since the beginning of my career. And I've seen this institution growing from pillar to post. So it's a great initiative to have this discussion on a dedicated subject like jaundice. So sir has given me a topic on cholangioscopy and EUS. In my 2.5 decades of GI practice, I consider these two investigations and two tools as milestone technologies, which has really changed the way we look into the treatment modalities of obstructive jaundice. So let me simplify situations for you. Like we all started doing endoscopies. So initially it was like luminal endoscopy. We used to do upper GI endoscopy, we used to do colonoscopies. And then we started doing side wing endoscopies, wherein till the lumen we were there.
वीडियो आ गई और आ गई ऊपर आ गई ये गया पीछे एक और पीछे ये
ठीक 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 So the subject given to me is role of endoscopic ultrasound and cholangioscopy in obstructive jaundice. So I have deliberately picked up obstructive jaundice. The topic was given to me was jaundice only because we understand that these two technologies are more relevant to obstructive jaundice. So let me start our discussion with history. 56-year-old post-cholecystectomy status male presented with cholestatic jaundice. Radiology was suggestive of dilated IHBRD and normal common bile duct. His imaging was done, which was showing following pictures. So we had a stricture and a stone at common hepatic duct. We had in the another picture shows there is a stricture there at the hilum. Hilum is preserved. Then we have some indentation coming from outside. There's another stricture which is happening, probably at CHD. If we go further, we find that there is a stone which is impinging from the outside. We call it myrices. Then we have a large stone which is practically occluding the common bile duct. If we go further, then we find such huge rock-like stones in post-cholecystectomy patients. And these are the patients wherein the flow of bile is obstructed. The bile accumulation into liver, raised alkaline phosphatase, and direct hyperbilirubinemia appears in these patients. So you have packed stones at one end after other, and you have the clips seen there, which suggest that this patient has post-cholecystectomy multiple residual large CBD stones, and the other is a huge rock-like stone in the common bile duct. So now for these two situations, we have like CBD stones causing jaundice. Another situation is biliary stricture, which is causing jaundice. So aim of treatment for CBD stone is clearance and the cure. The clearance and cure so far comes through surgery, which can be an open cholecystectomy or which can be a laparoscopic cholecystectomy. And the new equipment which has really changed the scenario is SPY-assisted cholangioscopy. When I said in the beginning of my discussion, we were doing luminal endoscopies earlier. In the ERCP, we used to stay in the second part of duodenum, and rest of the work was happening under the image guidance of contrast. Now we have a new scope which goes inside the common bile duct, which goes inside the pancreatic duct. So we call it as second space endoscopy. So in this second space endoscopy, when we do the procedure, we have access to the stone, we have access to a stricture, we can take biopsies, we can fragment these stones, and this is how the instrument changes the outcome of patients. So as for the management of common bile duct stones, if you have a common bile duct stone which is causing obstructive jaundice, if it's not a difficult stone, then we do simple basketing. We do a sphincterotomy and remove the stone. But if we have a difficult CBD stone, we call a difficult CBD stone as a stone which is more than 1.5 centimeter in size, or as and when the CBD oblique stone size is more than 1. There are multiple packed stones. They are narrow distal common bile ducts, angled common bile ducts, Myrizi syndrome, post-cholecystectomy cystic duct stones, biocele gallbladders which are not fit for surgery, and hepatolithiasis. These are the situations where normal routine ERCP will fail, and we will need the help of cholangioscope. Further, for biliary strictures, we can have benign biliary strictures, we can have malignant strictures. For benign biliary strictures, the options for the treatment are endoscopic and options for the treatment are surgery as well. There is a discussion on that, which one is better. And let's not go into that. But the reason, the most important thing is to know that whether we are dealing with a benign stricture or we are dealing with a malignant stricture, which probably changes the outcome of the patient. So when you have an upper CBD stricture, you use cholangioscope, you go there, take a biopsy. If you have a mid CBD stricture, you do a cholangioscopy again and do a biopsy. But yes, if you have a lower CBD stricture or maybe a compression from the head of pancreas, EUS FNAC can be done or a cholangioscopic biopsy can still be done. This particular equipment is really changing the scenario, how we're looking into it. This is how the equipment looks like. It gets fitted to the the routine ERCP scope. Through the ERCP scope, it goes inside. It enters inside the ampulla of Vater, goes inside the common bile duct. You have a good image, you have a nice image, and you have the therapeutic channel also. Through this therapeutic channel, you can do multiple therapeutic procedures like taking biopsies, picking up the stones, bringing them out, taking a laser fiber inside, fragmenting the stones, and taking clearing the common bile duct. So as if at all the hepatobiliary anatomy permits, now probably with the advent of this particular technology, we can say that CBD exploration should be thought later and this particular option should be given a priority. So this is how a laser lithotripsy is done. There is a fiber which comes through the scope. It just fragments the stones. And that is how a 30 to 40 minutes procedure, which is quite cost effective, is a daycare procedure. Patient goes home the same day evening. Even if you have a problem in the pancreatic duct, number of studies on the PD endotherapy with the cholangioscope is less, but these stones in the body of the pancreatic duct can still be fragmented. More and more data is coming in because the technology is further advancing. The scope size is going down. The lumen of the working channel is improving. The image is improving further. So this was about the cholangioscope. So what are the indications for this particular technology? Ubiliary system cancers, biopsies can be done. So when we do a biopsy, this is surgical conference, but there's important point I want to raise. With the advent of IHC, IgG4 related cholangiopathies are coming up in a big way. In our center in last 4 years, we have had avoided some 12 Whipple surgery because the diagnosis for them was IgG4 related disease. And these were the patients who underwent stenting along with steroids and then they had cure. Then gallbladder cancer, intraductal pancreatic mucinous tumors. We can give you a mapping of how much resection is required for the patient. Then radiation-free ERCP in case of pregnancy can be attempted with cholangioscopy. Now this cholangioscope is a single operator equipment, is a cost-effective. It is less morbid procedure. It's a daycare procedure and can be repeated if required. Now, this is how the instrument works. It gets attached to your ERCP scope. A single person can operate. These are the accessories available for the equipment. We have like basket snares. We have EHL probes. We have laser lithotripsy forceps for taking out the forgotten stents, etc. Now, when you go inside the common bile duct, this is how it looks like. Common bile duct. This is a normal looking common bile duct. This is a malignant looking common bile duct. You can go inside, take a biopsy. If you have a large CBD stone, this is a big CBD stone which is right in front of your eyes. You just have to take your fiber there and fragment the stones, and the stone comes out. The fragments
to form, creating a nice shock wave. If the probe is on the stone itself, you'll get more of a burn. So will not be achieved whatsoever. Shockwave will not be created. So under ideal situations, the probe should be approximately 2 millimeters from the stone. The way I achieve energy in the form of joules and frequency in the when this doesn't work, we can increase the energy to 12 watts.
20 minutes of fragmentation. There are 3 modes. This is hard stone mode, dusting mode. CBD can be cleared. This is about laser lithotripsy. There are 2 ways of fragmenting the stone. One is called EHL. Another is called the laser lithotripsy. EHL is dedicated for the cholangioscopy purpose. Laser is a multi-department equipment. Even urologists can use them for their routine purpose of stone fragmentation. Now, this is second equipment which is called endoscopic ultrasound for my PG colleagues. The great biotechnological advancement wherein you have placed ultrasound probe with higher frequency going up to 15 megahertz, which gives you very clear images right across the wall, because you can take your endoscope in the duodenum. So how it is of use in diagnostic purpose and therapeutic purpose, I will try and share it with you. 66-year-old male has metastatic CA head of pancreas, presented with cholestatic jaundice and cholangitis. His ERCP was tried but failed because there was too much of duodenal infiltration. So what were our options for this patient? He goes in for PTBD or he goes in for endoscopic bile duct drainage. I'll just take a minute extra, sir. 2 minutes. All right. So when you do endoscopic ultrasound, you are in the first part of duodenum. The place above is the first part of duodenum. So, oh, short. So this endoscopic ultrasound goes in the second part of duodenum. On the other side of the wall is the common bile duct. So it is quite clearly visualized, and you just have to puncture. It's a safe procedure. It has very low morbidity and it has very low complication rates. And then you can place a stent there. So when you see this black thing where the arrow was, so this is the area from where the needle comes in. The needle punctures the common bile duct. When you go inside the common bile duct, you push in your guide wire, and through the guide wire, you dilate the tract and you place a stent. So this is a very good palliation, which takes around 15 to 20 minutes to do. And this is how self-expandable covered metallic stent is placed in the posterior wall of the duodenum. And these are the patients wherein you can do procedure even when you are not able to reach to the ampulla of Vater. So a simple procedure, cost-effective procedure, non-mutilating, there is no scar on the abdomen, and a single stage procedure, unlike PTBD. So this is how the final picture comes like. So when you see this, the stent is seen in the posterior wall of the duodenum. If you see carefully, on the radiological picture on the left side, there is a duodenal stent also, because this patient had gastric outlet obstruction as well. So now this EUS has two kinds of scopes. One is a radial scope, which is called a diagnostic scope. It gives you pictures like your CT scan. You have a linear scope, which gives you picture like an ultrasound of abdomen. So the linear scope is on the left side, which is the needle coming out of it. So you can use it for therapeutic purpose, for doing all kind of procedures. This has really opened a new era in intervention gastroenterology now. So it helps us in doing staging of the disease. So inflammatory masses, which you cannot differentiate on chronic pancreatitis, you can do biopsies. You have elastography to give you the probable option of malignancy versus chronic pancreatitis. You can do disease staging with this equipment. You can do FNAC by providing histological diagnosis for those Whipple surgical patients who, unfortunately, in 15% of population will come out negative. Failed ERCP antegrade stenting can be done. Hepatogastrostomy can be done. Choledochoduodenostomy we just saw. And there is an edge procedure wherein we can do gastrojejunostomy by EUS guidance also, instead of a mutilating surgery in metastatic patients which are like not fit. As for the MRCP in the last presentation, which was such a beautiful presentation, nice pictures we saw. But in our unit now, henceforth, where there is biochemical abnormality and dilated CBD with no obvious stone seen on ultrasound, we take these patients to EUS, because the lower 1/3 of common bile duct, because of the gases in the duodenum, is difficult for ultrasound radiologists to visualize. So that is the area where, because we are right there, we have a 12.5 megahertz probe right near to the lower end of common bile duct. We can see it there. If there is a stone, we convert them into ERCP and complete the procedure. Therefore, the need for MRCP in our unit is no more there. The sensitivity is up to 84 to 100% for picking up CBD stones. Well, we can do EU staging, TNM staging for the malignancy. We can give you vascular involvement, retroperitoneal masses, peripancreatic and lymph nodes can be FNAC can be done for these procedures. These are the procedures. Just we shared the video where there is a failed cannulation or there is a dural infiltration. We can do therapeutic procedures through EUS. Thank you so much for your kind attention.
Next lecture is recognized Dr. Heera Ram, PTC. He is assistant professor in Department of Movement Radiology at MRCP.
Good afternoon, everyone, and special thanks to Dr. Mukesh Kalla sir to give me this opportunity. So previously, Kalla sir told about speak about the cholangioscopy and EUS. So I am going to talk about the PTC where EUS or ERCP fails. So its name suggests PTC. It's a percutaneous transhepatic cholangiography. So it's a radiographic technique employed in the visualization of the biliary tree, and this is diagnostic, and it can be used at the first stage in number of the percutaneous biliary interventions. Now there are multiple indications. The PTC is mainly indicated with evaluation of the biliary anatomy in the presence of biliary obstructions where ERCP is unsuccessful. Now where the ERCP is not feasible, where the anatomy is altered surgically, including the biliary type 2 Roux and Y gastric bypass surgery and the Whipple's procedure, PTC may be preferred over the ERCP for the pathological diagnosis of the hilar biliary stricture where the stricture is very tight and the ERCP guided wires cannot go through, where we play the role. Now, biliary system delineation in presence of the intra and extrahepatic biliary calculi. And the next, of course, to identify an obstructive cause of jaundice and differentiate it from the medically treatable cause. PTC also indicated if there is an inaccessible papilla, for example, duodenal malignancy and ampullary carcinoma, where the ERCP fails. It can be also management of the post-operative or post-traumatic biliary, for example, post left poly biliary leakage or accidentally CBD cut in the left poly. It can be also used in the percutaneous biliary stent placement in the malignant stricture, post-operative stricture dilatation in case of HJ stricture, and also used in stone removal where ERCP guided is unsuccessful. We can give access through the percutaneous, and then gastroenterologist can round out and then they can remove the stone and also can do laser. Now there are few contraindications which are not absolute. They are relative contraindications. Bleeding diathesis where we can correct the underlying cause. Gross ascites, we can tape it and then we can do PTC, and then biliary tract sepsis, of course, we can manage it and we can do PTC later. Now the procedure, before the procedure, we can have good imaging of the patients and have routine investigations, LFT and CBC and coagulation profile. Informed written consent sign for the procedure must be there, and 4 to 6 hour fasting, and stop the coagulation if any coagulation. The patient is on any coagulation. Of course, we do PTC in the cath lab, and usually the procedure is done under the local anesthesia. 99% of the cases we do this procedure under local anesthesia. In case of the patient is not cooperative or the system is not that much dilated and patient is tachypneic, then we do mild sedation. And patient should have IV cannulation, and prior to procedure, we give antibiotic. And then patient is, of course, have skin preparation, draping, and should be performed. So here is an example where you can see patient is a clean pen drape, and in the cath lab we do this procedure. And now we come to the equipment part. This is very important. You must know your hardware before the procedure. So these are the a set of the needles. First one is nap set. This we use when the system is not that much dilated. In this we use 22 Gauss needle and 0.18 guide wire with the dilator assembly. So this is the dilator assembly. This is the this one is the 22 Gauss needle. And in case the system is much dilated, then we use 18 Gauss Chiba needles and 0.35 guide wire. And these are the catheters which we use in the strictures where we need to close the strictures. So here you can see this is the C2 catheter. This is the CAMP and MP catheter. And then of course we use external and internal catheters. So this is, you can see the small catheter with pigtail. This is we use for external drainage. This is the Malikot catheter again for the external drainage. And this is internal external drainage 45 centimeter long, where we use in the internal external drainage. Now come to the technique. Technique is very simple. First, you should evaluate the liver, both the lobe, left and right lobe, and then you select which duct you want to puncture, and then give local anesthesia. You can see there is a dilated duct here, so you are targeting this duct percutaneously, and then under the USG guidance, you puncture the needle, and then put the contrast, and you delineate the cholangiography, and then through the puncture needle, you can put the wire inside, taking out of the puncture needle, and then put the sheath in, and then you can do further procedure. Here is the first case. In this case, we puncture the left duct under the ultrasound guidance, put the guide wire in, and then we remove the puncture needle and then put the sheath. Through the sheath, we put the contrast, and you can see delineate the anatomy. And here we can see there is a type 1 block in the distal CPD. In this case, gastroenterologist also ask for the intraductal sampling, though over the wire. First, we pass the wire in the duodenum, and then over the wire we put the breast sampling, and then we give the breast sampling in this case. This is second case. This is the young female lady who underwent lap cholecystectomy, and she referred to our hospital for the biliary leak management, and GI surgeon referred this case to me, and for the PTBD. So I punctured first left duct and then did cholangiography. Here you can see only left and right anterior system is delineated, but not the right posterior. So there is high level CVD injury, high level injury. So we decided to do the right posterior PTBD also. And here you can see in the second image, later image, there is a contrast leak which is going to the surgically placed drain. Here, under the ultrasound guidance, we punctured the segment 6 duct, and cholangiography was taken, and it shows that only posterior system is delineating, and through the puncture needle, we put the wire in. Wire goes into the leak side, and then we take out the puncture needle, and this sheath is put, and then the soap wire take out, and stick wire placed, and over the stick wire we place the external drainage at the puncture site. Here in the case 3, in case 3, this patient had IASGO stricture. Here we clearly see in the cholangiography there is a stricture. Through the stricture, using the catheter and guide wire assembly, we entered into the bowel loop, and then cholangioplasty was done. And after the cholangioplasty, external and internal catheter was deployed. This is case 4. This case is known case of CA head of pancreas. In the cholangiography, you can see type 1 block, and there is a distal stricture over here. And using the catheter wire combination, we negotiated into the duodenum, and then we did cholangiography as well as put contrast in the duodenum, and then see the length of the stricture, and then after the length of stricture, we can put this metallic stent. So here you can see the metallic stent is showing the stricture or the distal CBD, and post placing the metallic stent, we did cholangiography, and it shows the contrast flowing through the stent. And external drainage was put after the stent placement. We usually put external drainage to secure the access in case of hemophilia, or in case of stent obstruction, we can have access. Now there are no much post-procedure care, just antibiotic is enough. So here, if the patient is not affordable in case of distal biliary stricture or malignant stricture where we require stent, we can also put internal external catheter. There are not much complication. It's a very rare complication which includes bile leakage and biliary peritonitis, bleeding, and cholangitis. Cholangitis happens due to the contrast. Take home messages are percutaneous biliary access and image leads to intended beneficial outcomes in the majority of the cases. So clinician taking care of the patient with biliary tract pathology should be aware of signs and symptoms that indicate invasive cholangiography to be the next best step of the patient care. And we should have good pre-procedure workup and pre-procedure imaging. You must know your hardware well. If we follow the correct step of the PTC with good hardware, then we will never fail in PTC. And there must be post-procedure care, and we must know if the complication happens, how you manage it. Thank you. Any questions?
Thank you very much, doctor. And it's really very nice to look at the perspective of markets. Post-traumatic treatment to a multi-disciplinary academy. This session being dominantly on the radiological intervention and diagnostics. I would like to take the comment made by Dr. Ajay, which we covered that time regarding one package diagnosis of hilar cholangioscopy in Hudson's tumor, and it is actually available with MRI, MRCP, and MRNG. You can get answers to all your questions, but it's only that in clinical practice, including our center, we are complementing the new investigations with each other. Even in case of malignant masquerade of hilar cholangiocarcinoma, the diffusion can actually differentiate the occurrence of non-malignant structures like that we see from the malignancy. And then it's really heartening to know that how certain diseases can be managed in people which need simple procedures of removal of CT scans by liver equipment of cholangioscope. And the role of PTC has a very good kind of role in managing the edge-side strictures actually. With this comments and comments of co-chairperson, we would like to invite Dr. Varshney for this questions and coordination. I think let the co-chairperson.
Yeah, I think one of the areas I wanted to just give my 2 cents on is the role of especially a EUS or a spinal graded biopsy in living structures, especially the cholangiocarcinoma, the next degree of high level. It's going to be a level to integrate the gastroenterologist and surgeon. I can take. But for the PGs to understand the concept level as respect to health. So when you look at basic any test, be it EUS graded biopsy or spinal graded biopsy, sensitivity means there will be many false. Then we look at specificity, which is very few false positives. But from a surgical context, I'm also interested in something called the negative predictive value. So negative predictive value is if the test is positive, I'm not worried. Let it show, malignancy, let it show some autoimmune or tuberculosis, I'm happy. But when the test says it's negative, so am I happy to send the patient back home saying that you have no malignancy, or is this still a doubt? So when you look at the literature, the EUS guide back bioscopy, even those tests, the negative, though I have very much sensitivity and specificity, the negative predictive value is only 50 to 60%. So that means 40% of patients where the test is negative may still turn out to have malignancy. So that's probably the justification of surgeons and oncologists saying that, look at the clinical picture and the patient is fit for surgery. You should go ahead with considering the malignancy and accept that 5 to 10% of them may turn out to be benign. So that's one point I wanted to make. And the other aspect is the PTC. Regarding the PTC, I think excellent lecture by Dr. Heera Ram. But like in the context of ERCP, we should understand that PTC is also not an evaluation tool. It is mainly a therapeutic tool. When you go in for an intervention, you can use the PTC simultaneously to get some diagnostic information, but it's not a standalone diagnostic tool. We don't use PTC. Though I should say the quality of PTC in some situations, like a long-standing stricture, there's a lot of sludge at the high level where MRCP may over-report, and in the post-transplant scenario, where the stricture involves the confluence of drugs. So MRCP may over-report these as more complex strictures, and in those cases, PTC can actually help us delineate the anatomy better. So with this, I'd like to call upon Dr. Peeyush Varshney as lead questioner. He is assistant professor in Department of Surgery Gastro at AIIMS.
Thank you, Chairpersons. First of all, I would like to thank my teacher, Professor Kapoor sir, for this opportunity as well as organizing this dedicated course on jaundice. So I have got two case scenarios for basically postgraduates. If the time permits, I will ask the second also. I will just proceed to the first. My slides are not moving. Slides moving. So first case is 64-year-old male. He was referred to a surgical team on call. He has been complaining of pain in the right upper abdomen and generalized itching. His daughter has noticed recently yellowish discoloration of skin, and symptoms began about a week ago and have got gradually worse. On further questioning, he had complaints of passing dark urine and pale stools for the last few days, and he usually fit and well and does not drink alcohol and denies any recent foreign travel. On examination, he is afebrile, vitally stable. He is clinically jaundiced with some tenderness in the right upper abdomen. Liver is enlarged, but gallbladder is not palpable. The rectal examination reveals pale stool. So I'll just give you the preliminary basic blood investigations. So he had a TLC of 12,000 with total bilirubin of 20 and enzymes of 140 and 100 with alkaline phosphatase of 526 with INR of 1. So can somebody comment what do these blood tests show? Any postgraduate? Any postgraduate, what do these blood tests show? Is it a conjugated or unconjugated hyperbilirubinemia? Is it in cholangitis? Anybody? So basically, these tests indicate that patient is having a conjugated hyperbilirubinemia. The direct bilirubin is 13.5. So what are the probable cause? And what will be the next line of investigation? Anybody? Postgraduates. These are the most common scenario that will be encountered in your outpatient clinic as well as daily practice. So this is the most common scenario in the obstructive jaundice that will be encountered by you. So anybody, what are the probable cause? And what will be the next line of investigation? USG whole abdomen, exactly. And the probable cause is obstructive jaundice. The level cannot be ascertained at right now. So the ultrasound was ordered and subsequently a CT was ordered. So this is the CT and this shows a classical sign. Can somebody tell me what is this sign and where does this sign frequently occurs and where can we diagnose this sign? Anybody? So what is this sign called as? So it is a double duct sign and it is most commonly seen in malignant cases like CA hepatopancreas or periampullary cancers. Can anybody tell me any benign cause of this sign? Yeah, chronic pancreatitis. Any other cause? So sometimes we can also see in the cases of ampullary stenosis as well as gallstone obstructed in the distal bile duct causing edema
in the pancreas can lead to this sign also. So they are rare, although rare, but it can also be seen in benign causes. So that's it. I've been asked to take some questions from the chat box also. Any of the chairperson or somebody from the audience can. So Dr. Yasir Hussain has asked investigation of choice for cystobiliary communication. Maybe Phani sir, you can answer this.
I'm studying in the setting of a chronic acute or chronic hepatitis E. coli. So the first choice would be a non-invasive investigation like an MRCP, and that would be the investigation choice for the cystobiliary communication. But sometimes when you're already done an intervention, like for example, you already put in endoscopic drainage, you want to take out. At that point, when you're taking out, people also use intervention invasive like ERCP to make out. So first choice would be a MRCP, but instead of some selective, we can always use a ERCP.
It's like to be a highlighted cyst problems asking about, so right way would be going the way of.
Okay.
Yeah,
So
take that ISBRD.
So there is one more question from Dr. Yasir Hussain Wani. So IHBRD diameter, intrahepatic biliary duct diameter cutoff for selection for PTBD. Maybe Dr. Heera Ram can answer this.
Mike.
So there is no cutoff diameter. It can be done in undilated system like in biliary case. We did case for this case. We did it 2 days back only. It was totally undilated. So there is no cutoff.
I think yes, everybody will in this house will agree.
The thing is like what Hiran said. I think in a dilated to do undilated PTBDs, it's you need an expert radiologist because there's a chance of a lot of artery injuries, forebrain injuries. So anyone can do it in a dilated, but if you really have undilated, like in the city, probably in the city, there will be probably 1 or 2 experts. You know, call them for this. So it's not easy.
So that's right. So we are fortunate enough. We have a good intervention radiology department, and we have 3 young faculty colleagues there. They are expertise. They have expertise in dialysis. So
I'm saying
yeah, definitely I could give me. Definitely. So we are fortunate here.
So I think for the postgraduates, if the system is dilated, then it is easy to do a PTBD. But if the system is not dilated or undilated, then you require an expert percutaneous intervention radiologist.
The top question is when to refer to the expert. When will you say that this I will not puncture?
Maybe 2 mm, 3 mm. I don't know.
I mean, what is a comfortable size to puncture for the non-specialist, non-expert?
Yeah.
Say loudly.
Another this is having a very soft or fatty liver. That's another dangerous scenario for PTBD. Post-transplant scenario, very fatty liver. There's a lot of shearing in the area.
Yeah, I think now the experience in transplant is increasing. So we have intervention radiologists that are being experienced in these kind of interventions. Yes, sir.
Regarding cystobiliary communication, one investigation is help use MRCP. So if you find a pad and stay inside the highlighted, that you should point that there has been a biliary communication.
Okay. Thank you. Any other question from the floor? Okay. So there is a question: radiological features of tubercular pancreatic head mass.
Yes, sir.
Maybe ma'am, you want to answer? Or Dr. Vineet is here. Sir, would like to answer this. Mike. Sir.
Yes. There are no definite
तो Nilius. ये तो हो गया.
Tubercular mass is involved in the pancreas, but often there are conglomerate of necrotic lymph nodes around the.
You are not audible, sir.
And again, we may find sometimes calcification in the region. So there are definite diagnostic missions.
Yeah. Thank you.
We can continue for another. Can I add one?
Yeah. Yes.
2 point I want to make, like when we are planning any drainage procedure like ERCP or PTBD, especially in the management of obstruction or resectable disease, I think it is always better to do a cross-sectional imaging before putting this catheter. This we emphasize to the postgraduate because putting this catheter, especially in the management of obstruction, can create an artifact and it's difficult to measure the longitudinal extent of this disease. And second is whenever we are planning any PTBD for the high-level carcinoma, the surgeon should decide which side we should use, left or right, because it depends, because we are supposed to drain the FL. So it is most easy to do left, otherwise we get always left. Even we are planning the left. And my question to Dr. Heera is, like you showed the PTBD as a palliative procedures. So putting a metallic side to the PTBD catheter. The same thing or do you wait for some time to place that to make sure?
Maybe I can ask one question. That is a very common question we surgeons encounter. Differentiate a cortical cyst from a dilated CBD, a passed out stone, because sometimes they're always confusing that is it a cortical cyst or just a passed out stone? So, any comments from the chairpersons or from, yeah.
It's not very common in cortical. Another important radiological feature would be the stone and the obstructive jaundice by and large, unless it is tied towards A or beyond cortical cysts, which are very rare, those have secondary bi radical damage, which appears to be a little different than the type 4 cortical cysts. And type 1 cortical cysts will be normal in the panic behavior. Because these are the two different points in the radiologist would like friends for the funds.
This type 1 cortical just mild film from that more than use. One is parotid diverticulum, of course, we're assuming that it's normal LFTs and no symptoms. Parotid diverticulum is one thing which is ignored on the side, that causes the skin of dilation. In a older patient, like a 70-year-old, when you see dilation with normal LFTs, do a side viewing with normal, I would not take it this very seriously. But in a younger patient, it could be weird or either follow up closely. One approach would be do a wide sphincterotomy before you do your prostatectomy. And I mean, again, patient comes with gallstones and dilated CBD, I'm assuming. So before you do a wide sphincterotomy and then follow up, and over the years, if the folks of dilatation, you could.
I think most of the endoscopists will also agree that ideally we should drain it and then wait for the subsequent imaging. Yes, sir.
Yes. Few comments about post-Rosenberg gastric bypass biliary access for therapeutic purpose. So we have that 4 endoscopic approach where we consider trocar into the renal stomach and we can do EUS or any intervention whatever you want to do that so that is to add on the second is recurrent bypass stone after cholecystectomy. We need to check for the contaminated long cystic may be the source of recurrence of these stones, and we have to remove them unless until otherwise we will not be able to treat these stones.
We are already discussing. Yes.
The point about the political system.
Yes, sir.
Mildly dilated. So the various types of political system as per the classification, it's usually not difficult. Difficulty comes in that what we want you to call the compost, right? It's mildly dilated.
Exactly.
CBD, those are the areas. But suppose we are unable to differentiate. The question now is, should we, is it necessary to operate upon those mild dilated CBDs? Because over the years, previously, we used to think that every polylocal cyst has to be dead surgically, especially in younger patients because of the associated risk of malignancy. But over the years, with the transplant experience, we've seen many donor MRs where the CBDs are dilated. These are not no gallstones, obviously, and young patients like in their early 30s or late 20s. So we have followed these up, and the CBDs were mildly dilated around 11, 12 mm. We just followed them. There's nothing to do. So I don't know what should be, should they really be treated? That was my point.
I think maybe some of the senior members can answer this.
I think as far as the consider the material that MR for a liver transplant and do some sort of patient a comparative as a scientific study comes up with whole student younger patients. Say 10 mm will be not a factor of concern. It is 13, 14 mm, and you're not very sure that the stone has passed. After you keep it a follow-up and observation, you can come to conclusion. The majority of the time, people do believe operating when compared to very elderly patients or somebody who wants 60 years old.
Maybe chairpersons can conclude this session. Thank you.
Thank you very much, chairpersons, the speakers and the lead questioner. That brings us to the end of the pre-lunch part of the course. But before we break for lunch, we have a very auspicious small ceremony to perform, the traditional lamp lighting. For Dr. Dulundu, the lamp lighting is a very traditional Indian ceremony whenever we do an auspicious thing. And it is supposed that the light dispels the darkness. So in any academic activity, we usually do the lamp lighting, that the knowledge will dispel the darkness of ignorance. So it's a traditional activity, and I'm very happy that the Chairman Emeritus of the Mahatma Gandhi Medical University of Science and Technology has agreed to be present. We also have the Vice Chancellor of the university, Dr. Sudhir Sachdev, and the Principal of the Mahatma Gandhi Medical College, Dr. Swati, and to our senior administrative colleagues, Dr. Ender Dulundu, who is the President of the International Association of Surgeons, Gastroenterologists, and Oncologists. So I request all the esteemed persons to kindly come and do the lighting. Dr. Dulundu. I'll also request Dr. J.M. Mehta, one of the senior most surgeons of Jaipur and the former president of Indian Association of Surgical Gastroenterology. Oh.